Good evening, everybody. Hello, Vikas sir. How are you? Hello, Zafar. We'll just start in 5 minutes. Okay. Just waiting for Carlos to join us and then we'll start.
Yeah, Carlos is joining. Hi, Zafar sir.
Hello, hi, how are you? Good evening, everyone.
Good, good, good. Carlos just messaged, he is joining in.
Hello.
Hi, Carlos. Yuvraj here. Hi.
Hey, Yuvraj. Hello, Pradnya.
Yeah.
Hi, Carlos.
How are you?
Good, good.
Busy night with the kids back there, huh?
Sorry?
I think I saw some of your kids going back there, walking around. So I was saying,
Yeah.
busy night, working and taking care of the family. How are you, Yuvraj? We haven't spoken so much.
Yeah, I'm all good. I'm all good. Yeah. Thank you so much for accepting our invitation, Carlos.
Thank you for inviting me. It's
Yeah.
a pleasure. It's just a tough time. I'm usually not so tough at getting to speak. This is a great opportunity, but it's just a tough time. But it's a tough time for everybody. The last few months, I mean,
Yeah.
and whatever's ahead of us is just crazy.
Yeah.
How are things in Mumbai? Are you guys out of lockdown already?
Yeah, it's a kind of a partial lockdown right now. Essential services have been allowed, and a few of the clinics have now just started accepting patients. So
Okay,
yeah.
with like special conditions or measures.
Yeah. So even we are taking patients with acute care, those who need in acute symptoms, we are accepting them. So yeah, with precautions, we are taking one step at a time and seeing how it goes.
Yeah.
Okay, I think we should start. Pradnya, we should start. I think it's almost 8 o'clock. So I think yeah. Okay, we'll just start recording. Resume recording. Okay. Good evening to all of you. Okay, I hope all are safe and having a pleasant evening. It's 8 p.m. in India, so it's a typical weekend, and we are all now. Most of us must be at home, relaxing nicely. So the intention of creating this series was to recreate the discussions which we used to have after our clinic hours in positive, in our clinic. That is, we used to, whichever patient we used to see throughout the week, we used to identify questions, and on the last day of the clinic, we should sit together from 8 o'clock to 9 o'clock, order a pizza, and just discuss relevant burning questions. And we used to try to share our experiences, share evidence which we may have read, and find answers which are absolutely precise to the question at hand. And we thought, why don't we create something like that for a bigger audience? And with that as an intention, as a motto, we thought of creating this series where we are taking up questions which we feel are very relevant to clinical practice in today's clinical practice. I'll start sharing my screen. Share screen. Anna? Okay. Very nice. Oh. Okay. Okay, I'll start. Second question. Just a second, guys. Just a second. Sort this out. बराबर आ रहा है. You are able to see me also. Yeah. Okay, guys. So we start with the presentation. I see Bhavana ma'am is there. Good evening, ma'am. Thank you so much for joining us today. Bhavana ma'am was my teacher in KEM when I was doing my masters, and it's really great to have ma'am for this small discussion. And I hope with Vikas sir, Bhavana ma'am being there, I hope I'm not making much mistakes too. So,
No, Yuvraj, you'll do very well. Good evening and thank you.
Yeah. Yeah.
Don't worry.
Okay. So as I told, the intention was to rake up some interesting topics in musculoskeletal and sports physiotherapy and find very, very precise answers to the questions. Okay. So we thought of first the topic to be. Can you see the second slide? Second slide. Okay. Okay. So yeah. So as I told, there's some of my teachers who are there, and we also have some of our students who are also there. So the mission behind this series is to create a better clarity in the thinking of students and in their action, creating a broader sense. We see a lot of students or young clinicians sticking to one school of thought, and the idea was to encourage them to explore all other schools of thought also that way. And thirdly, most importantly, we wanted to discuss something called as the evidence, the patient-based approach, and which we will discuss about this a little later about the patient-based approach. The information which we are going to speak today comes from evidence, comes from our experience, and we have some wonderful experts today with us, like Carlos is there with us to speak on manual therapy. So that is what is going to happen. We are going to be bold. We are going to break some myths head on. We are trying to create conversations which are very engaging. And most importantly, as you see, we want to keep it fun. We want to keep it light-hearted. Okay. So as we see musculoskeletal physiotherapy, if you see, yeah. So back in 2002, when I had started my education in my graduation in KEM, we used to have diagnoses like osteoarthritis knee, and the books which we used to read would be talking about the biomedical model, where we used to discuss a lot on pathology. We should also discuss a lot on why and the management of a patient will be based on his medical diagnosis. The diagnosis which we physiotherapists had didn't differ much from what the orthopedic surgeons would be having. And then as we went ahead into our third DPT, we were taught about a biomechanical model, where we were taught about how what you say a laterally shifted patella might contribute to alter arthrokinematics of the knee, and that contributes to pain. And then our management would be more towards correcting this imbalance around the patella. And there was a combination of the biomedical and the biomechanical model which we used to do. And this continued even when I was a lecturer in MGM. We used to teach the combined biomedical and biomechanical model to our students. What we have seen in the last few years, in the last, I would say 10 years, there has been something called as a patient-based approach, where now there is a more and more emphasis being laid on the rather than all the impairments, how to identify the correct impairments. And the treatment now has shifted from correcting everything to correcting the precise impairments which we think are contributing to patient's problem. The management which we are going to do will depend a lot on what the patient wants from us. So that is how musculoskeletal therapy has evolved over years. So that's the thing. In today's small talk, we are going to discuss the same thing. The same thing is as that what was existing, what is the new thing in terms of manual therapy, in terms of exercise therapy, and towards the end we try to make sense of, okay, there is so few of the old concepts are not evidence based now. So how do we work in the current scenario? That is the thing. So with that, I will hand it over to Carlos. Carlos, I had the pleasure of meeting Carlos during the MGM World Spine Care project and his visit to India a couple of years back. Carlos had taken a lecture for us on pain, and I remember the clarity of thought he had, uh, the knowledge which he had was amazing. And that is when when we decided to conduct this session, we thought the best person to talk on this will be Carlos. Carlos is a doctor of chiropractic. He is from Spain. He also has a master's in neuroscience, and he is currently pursuing his PhD in neuroscience at the University of Quebec. He has a vivid experience of working in different settings. He has worked across Europe and done a lot of voluntary work in India, in Africa, in Nepal, and other countries, and in Brazil also. So, welcome, Carlos. I will allow you to share screen, and please tell us more about the current concepts of manual therapy and how it works.
Great. Thank you very much, Yuvraj. Just to confirm, how much time do I have? Can you let me know when I
Carlos, you
should
can take
finish?
30 minutes is also fine. No issues about that.
All right. I'm just going to set up an alarm because I'm not very good at this and I tend to go over time and I really don't want to take too much of you guys' time. Anyway, first of all, do you hear me well? Can you hear me well?
Yes.
Okay. So I guess the Zoom technology works. It's great to be here. Thank you for inviting me. Thank you, Pranya, for being so insistent, and thank you, Yuvraj, for organizing all this. It's really an honor to be able to be with you guys from so far away, 3.5 hours time shift over here. And it's really an honor to speak to all of you who are interested in spending time 8 p.m. on a Saturday to learn more about how to better serve your patients. So this said, I would like to first introduce a little bit the topic that Yuvraj has said, but if possible, my intention will be to go slightly towards neuroscience because it's my realm. It's where I can maybe explain more things of what we think is happening with manual therapy, particularly spinal manipulation. I'm very focused on spinal manipulation because it's the main tool that we use as chiropractors. But I'm also aware that I won't have time to go into much detail. So this might leave just enough space for Yuvraj and Pranya to invite me again sometime. So maybe that's just what needs to happen. So let me see if I can share my screen. All right. Okay. Can you all see the main screen? I'm not getting much feedback. Can anybody?
Yes, we can.
Yes, sir.
Yes. Okay.
Yes, we
Great.
can.
Great.
Yes,
I know
sir.
if anybody could unmute and say like you guys did now, it's perfect. So the idea is to try to explain from my perspective, because even if we dive into the research, you don't always find everything that's out there. But from my perspective, from what I found, how we can explain nowadays what we do with manual therapy. I understand that manual therapy is not obviously the only skill that physical therapists have. For chiropractors, it's very, very predominant. We are very reliant on manual therapy. That is also changing currently. But I believe that also the research will lead us towards a place where manual therapy will find its place. There is currently an ongoing debate. You can see this very, very hot on the social media, where many, let's say, evidence-based physical therapists and chiropractors are really going away from manual therapy. Why? Because the evidence is not as strong. Why is it not as strong? Because it's difficult, mostly because having a placebo for manual therapy is very difficult. So it's one of the interventions where you have the toughest time really creating a good evidence base. So let's see what we have for now. And again, I apologize, I will not have time to go over the whole detail as much as I would like to. It's also a complicated time. I'm going through an exam, but I wanted to say that I'm definitely open if through Prania or Yuvraj, you guys want to send me later questions, please go ahead and do it. So I think this is a very good place to start. This is a paper that was published by Bialowski and his team. They're a physical therapist. Well, he is not, all of them are physical therapists, but most of his team are. 8 years ago on one of the journals where we published most of the research on manual therapy, well, a lot of it, not most, but the Journal of Electromyography and Kinesiology. And this is specifically a paper where it's a review, it's just a narrative review where he discusses what is the perspective from the physical therapy point of view on manual therapy. And in particularly, he talks about a technique on spinal manipulation. This is a special issue on 2012, you can find it. There's around 12 papers, I think, on all dimensions of manual therapy. And in this perspective, he talks about two options. As a physical therapy, you can make decisions based on two things. Either you make decisions based on the biomechanics of the patient when you apply your manual therapy tools, or you make decisions based on the clinical presentation using, for example, clinical prediction rules. So when you read this paper, it's a pretty short paper. Bialowski underlines a couple of aspects of manual therapy, specifically spinal manipulative therapy. And he talks about the accuracy. Okay, it's not easy to be accurate when we lay our hands on people. We think we are on T9. We think we are on the teres minor, sorry. We think, no, you're not on the teres, you're on the infraspinatus, but our accuracy is not as good as we think it is. And actually some research shows that even with training, this doesn't improve so much. Inter-examiner reliability is not so good, which means if you put 10 physical therapists, they might find 10 different things. And same applies for other professions, probably. Not just the accuracy is not so high, the specificity is also not so good. Even if you're on the right place, when you put a force to a muscle or to a joint, that force is spread. Typically, if it's a high velocity, low amplitude force, it's easier that well, if it's high velocity, high amplitude, it's even more, but the force gets spread over segments. So let's say you want to affect the T1 segment. You have high chances of affecting definitely C7 and T2, but also very likely C6, C5, and T3, T4, etc. So it's not easy to really measure, and it's not easy to be specific with the application. Even when you choose different techniques, there doesn't seem to be much differences in outcomes. So Bialowski advocates for a more general biomechanical effect. He is a manual therapist, or he does research on manual therapy, and he says, yes, this is important, but let's not think that the specific biomechanics are what we are changing. We are putting a stimulus, we're putting forces on the body, and then those forces have specific or more specific neurophysiological outcomes. And it's those outcomes that I would like to talk to you about, at least part of them. We know that through putting forces in the body, just like through exercising, or very similarly to exercising, there is a general neurophysiological effects that has consequences on movement, muscle tone, and other aspects that if we have time, we will explore. So when we talk about accuracy and specificity, this is in particular for spinal manipulation. Do the parameters influence the outcomes, and do they influence the biomechanics as well? Well, there's not a ton of research, but I've compiled, you can see some of the same authors all the time, but I compiled some of the research where they're looking at, okay, is mobilization and manipulation the same when we compare the biomechanics? So if I mobilize a patient to the end range, or if I mobilize, but then I put a thrust, do I make a difference? Well, Funabashi found that the peak forces do make a difference, and that spinal manipulation in that sense will be superior to mobilization, but there's not a lot more. There's not a lot more in that sense. There's some studies also on amplitude and site of application. And we know that the amplitude of the force and the place where we put our forces also changes the loads that the different tissues perceive, particularly the posterior joints in the spine and the ligaments. What does this mean? That, if my force is higher, I will have more impact. What do I mean by site? Well, if I want to influence L5, even if I'm not very precise, being on L5 will give me more chances of influencing the biomechanics of L5. This is common sense, but unfortunately it was not researched until recently. And most of it is done, not all, but most of it is done on animal studies, not a lot on humans, actually. So we know that the site of application is important because it might change the kinematics as well. The kinematics, the way we move might change with this. And this could also help explain the long-term effects of manual therapy. If we're able to change the way somebody moves, this can have long-term effects. Then when we look at the neurophysiology, like I was telling you before, most of the studies, if not a large majority, are focused on when I write here, MS is the muscle spindle response. So we know that through, specifically, this is talking about spinal manipulation, there is a muscle spindle response, a strong muscle spindle response. What does it depend on? Well, for example, a very recent paper by Reed, there's no effects on direction. So you probably all have learned or are learning some techniques for manipulation mobilizations, like, oh, you have to go P to A, you have to go on the convexity, concavity. There is not much research regarding whether that has an influence on the nervous system. The direction does not seem to have an impact. It does seem to have an impact on the biomechanics, or it could, but it doesn't look like it has an impact on the neurophysiology. The contact site does have an impact. So again, we're not very accurate, but if we could be accurate, being on the right segment has more chances to affect the right segment. That makes sense too. Also, when we talk about the type of forces that we're putting, we know that greater amplitude or greater loads, greater velocity is usually better to have a muscle spindle response. And here we're talking specifically about spinal manipulation, where we have a high velocity component. So if you're learning high velocity techniques, being fast is important. And it's been shown to have a higher muscle spindle response. Loads is probably related to velocity and duration. Duration means the shorter the better, which is related to your speed, which is related to your acceleration, so forces. So you do need to be fast if you want to use fast techniques, high velocity techniques, but the direction do not seem to be very important. So what is really happening? How can we explain all this? I like this quote. It's by a paper that's on a completely different topic, but it talks about whether movement affects low back pain. This is a very good paper by Laird, published last year. They were looking through kinematic analysis, through motion analysis, whether specific movement training and specific movement patterns has an influence on low back pain patients versus control people. And one of his main conclusion is summarized here. We see differences. People with pain don't move the same as people without pain. But that doesn't mean that the poor movement patterns are responsible for the pain. This is something that us as chiropractors, you guys as physical therapists, I mean, we have it as a bias. We think, oh, you are not, you have pain because you're not sitting well, because you're not moving well, because you're not bending correctly. However, this is just one paper, but most of the research points in this direction. We know that there is a correlation between poor movement, poor biomechanics, and pain, but we don't know what causes what. I will show you some more of this. These are two, I think, very good papers. They're both reviews, I think, both narrative reviews. The title just tells you everything. I mean, they even tell you the hypotheses and whether the authors have met their hypotheses or not. So the first one, it's clear, the fall of the postural structural biomechanical model in manual and physical therapies. Pretty much the author is implying that what we thought was the cause of back pain, because he chose the example of low back pain, which is poor mechanics. Well, we don't have any evidence for that. The second paper is very much on those lines. The biomechanical model in manual therapy, is this an ongoing crisis, or do we need to revisit concepts? And I think this is where we can find some hope. I think we can use a lot of knowledge, a lot of terminology that we used to use, but the terminology particularly probably needs to be reframed. We need to rethink some of these models, and we need to see how they fit in the contemporary evidence that we have. So you have a lot of papers on this. This is a very good summary on how manual therapy might work. This is a paper by Bialowski, again, as you can see, but it's 2018 on JOSPT, one of the leading journals too, Journal of Sports and Orthopedic and Sports Physical Therapy. And here they propose a general model of how manual therapy can work. And interestingly, if you look at what's happening, here to the left, you have the mechanical stimulus and the changes related to motion and biomechanics. But if you look at everything else, it's nervous system, it's neuroscience, it's neurophysiology. So if we really want to understand what's going on, we don't need to dismiss the mechanics. We just need to go a bit over that, try to read and be up to date with the research, and not to be stuck on old concepts and knowledge that is now outdated. In order to do that, we need to study neurophysiology and neuroscience, which is much more complex, but it's also fascinating. You can see here how many things interact when we are applying manual therapy. Well, not just the biomechanics, inflammatory mediators. We have changes in motor neuron responses, autonomic nervous system responses, even higher up, endocrine responses that involve the beta endorphins, or that involve, for example, the cortisol system. Non-specific responses, which have been assimilated to placebo, but that are very important when we're laying hands on someone. So since I'm not going to have much time to detail all of this, I really encourage you to go look at these papers and start also realizing what is the evidence saying about what is happening when we are laying hands on someone. This is a slightly more recent paper on what are the mechanisms more specifically for spinal manipulation. And if you look at what's going on here, the author, Geyer, he talks about the mechanical stimulus, but then, well, it's true that the paper is very focused on neurophysiology of the spinal manipulation, but all the effects are related to neurophysiology and neurophysiological effects. And you can see again some of the same stuff happening. We can see that there are changes in the autonomic nervous system. We have descending inhibition that can explain some of the things that are happening. Corticoids, hence endocrine changes, anti-inflammatory effect. And all these things, we're just beginning to grasp them. While the biomechanics, I'm not going to say that the research is finished, not even close to be finished, but we know a lot better what's happening. And in that sense, most of the research doesn't support biomechanical models where we really need to, for example, push a vertebra that's posterior to the right, and we need to put it back anterior to the left. And I'm really not favoring my profession here, because we're really based on this type of beliefs, and I teach some of it, but we need to be able to put it into a proper context. So out of that same series of paper I was talking to you about on the GAK, you can also find this other paper by Picker and Bolton. They talk about somatosensory activation with spinal manipulation. I think this is the best start for neurophysiology of manual therapy in general and spinal manipulation in particular. They summarize the evidence until 2012. They have actually directed research after that, which is mainly focused on muscle spindle. Muscle spindle research is very important for any manual therapist. And the impact that you have through slower forces, like let's just say myofascial work in general, is very different from the impact that you can have through high velocity, like manipulation, for example. So what happens during both applications of manual therapy is that receptors are activated, somatosensory receptors, somatosensory terminals. Which are these receptors? As I told you before, most of them are muscle spindles. We know that there are likely receptors on the disc, there are receptors on the ligament that are probably going to be activated, but there's not a ton of evidence in that sense. We know that there's also mechanoreceptors in the joints. As you can see here, this is a potential explanation. This is also from Picard, same author as the previous paper. And he talks about joint receptors and muscle receptors, but there's a lot more evidence for muscle receptors. And from the data that we have so far, we know that even if you use high velocity stimulation, the classic cavitation, the popping sound, is not really necessary, at least for pain relief and for changes in neurophysiology. Not that we know, at least not so far. So these receptors are activated when we put our hands on people, when we mobilize, manipulate soft tissue and joints, both. It doesn't matter, it's just going to be a different extent. We know that when we lay hands on people, there are changes that are also local. The tissues that we touch are changing as well. There's not a lot of research on this, but there's this very elegant paper. I must say that it comes out of my institution in Madrid. That's also why I'm a bit biased towards it. But I think it's a very elegant paper on rats. It's made on rats, and they're looking at spinal manipulation induced by a mechanical device, so like an instrument. And they're looking at what happens to osteoporotic bone. Because the hypothesis was that through the local forces, there's local changes in the tissues through myokines, cytokines, growth factors that also influence the tissue through mechanical changes. And very interestingly, what you can see here, the left image is the bone of rats that were not osteoporotic. On the middle, you can see the bones of rats that were osteoporotic before manipulation. And on the complete right, you can see what happens after, if I'm not mistaken, it was 4 weeks of manipulation, only 4 weeks, 3 times per week, one manipulation directed to the tibia. And you can see amazing changes on the bone trabecula, which means, okay, we are affecting local tissues. And these, okay, we're talking about rats. So you always have to be very careful when it's animal research, but we could be affecting, let's put it that way, we could be affecting also local tissues, for example, by stimulating, in this case, MGF is a myokine, it's called mechanogrowth factor. So we're putting hands on people and, sorry, is it time? Oh, sorry, I thought it was time. Give me a few more minutes, 5 more minutes.
No, you can carry on.
Okay. Yeah, somebody's mic just popped up. So anyway, how does this happen? There are some hypotheses, but we still don't know. The overall idea behind this is that it could happen through reflexogenic responses, so myotatic stretch reflex. And if that's the case, we know that the spinal manipulation, since it activates receptors in the periphery, since it changes local tissues, it probably has an impact on the spinal cord. This impact is what we call segmental changes. So this is again where, okay, is specificity important or is it not? Well, it's hard to balance. You know, the research doesn't show that it's that important, and more especially, it shows that it's very hard to be specific in one segment. However, we know that the analgesic effects of both manipulation and mobilization are segmental, which means if you want to relieve shoulder pain, you have to mobilize the shoulder. Okay, that's not so hard. But if you want to relieve pain that comes from C7, you have to mobilize or manipulate C7. If you are 2 segments above and below, we don't know if the effect is going to be significant enough. So we know that spinal manipulation and mobilization decreases mechanical pain sensitivity. The thresholds go up. That's how we know that sensitivity goes down. Which thresholds is pain pressure thresholds. You can measure them very easily through algometers. You can do it in your clinic, and it's not expensive to have an algometer. Well, if it's validated, it's more expensive. But so you have to apply it on the segment and or on the dermatome related, dermatome or myotome. So that's something that you all know. That's something chiropractic was based on this. If you have a problem, you know, here, you're like, okay, I want to see how C6 is doing. You know, that kind of story. We know that the effects are very clear for mechanical pain, but not so clear for chemical or thermal pain. Actually, for thermal pain, it seems like there's no effect, which makes sense. The research shows that these effects are more valid or specific in the cervical spine, probably because also the nerves are shorter in the lumbar spine because of the choroid equina and the anatomy. The nerves are longer, so you can have other factors affecting. And we see that healthy subjects manifest this decrease in threshold or in, decrease in sensitivity, increase in threshold. But people with pain, it's not so sure. The research does not have the same conclusions. We also know that these effects are short lasting. They don't last more than 30 minutes, which means that how can we make a difference in someone's clinical presentation? Well, we probably need to go further. One of the most important findings concerning spinal manipulation, and there's at least one study with mobilization, is that it reduces, more likely on the segmental level, temporal summation of pain. I don't want to go into the details of temporal summation because it's complex, but you probably remember the C fibers. C fibers have a tendency to summate, to increase their response through repeated activation. And this happens in most musculoskeletal pain and definitely on chronic pain. So we know that spinal manipulation can decrease this. And this is very important regarding chronic pain patients because, as you know, they're very difficult to handle. So we know that this could be happen. This would be one of the mechanisms. And temporal summation is very related to plasticity in the spinal cord. So we don't know yet, but there is a hypothesis that spinal manipulation could reverse some of this plasticity. And then we can explain how this could have long-term changes. And I'm talking about spinal manipulation because it's my realm. But again, mobilization and most manual therapies are going to use very similar mechanisms. We also know that there are effects on the autonomic nervous system. In general, if we summarize what we know that the effect is also segmental. So it's like reflexogenic on the same segment. And it's manifested on an increase in sympathetic excitation. Actually, this could be the opposite when manipulation or other techniques are applied to the upper cervical. So whatever's been studied in general has been studied in the thoracic spine, but a few studies on the upper cervical show probably opposite tendency. So instead of sympathetic, maybe parasympathetic, which is one of those old theories that might be true if the research continues to go in this direction. How are these autonomic nervous system mechanisms mediated? Well, we have some theories. Most of the effects are probably segmental, as you can see here, segmental reflexes that can affect, for example, heart rate variability is one of the variables that has been measured, or skin conductance, which is correlated with the amount of sweat that you have, so sympathetic activity. But there are also some hypotheses that through the inputs that we put on somebody's spine or somebody's somatic tissues, we can affect autonomic nervous system centers in the brain. And these autonomic nervous systems, these ANS changes in the brain could eventually have an impact, for example, on the cortisol system that we mentioned before. So I want to more or less finish here because we're approaching a point where, okay, now we're talking about supraspinal, not just spinal or peripheral, but supraspinal mechanisms. And it gets very complex here. There's a lot of recent literature, but I think it's interesting that at least I bring it up to you guys. Right before talking about supraspinal mechanisms, just a quick note on motor changes. There's quite a few studies on motor changes related to spinal manipulation, mobilization, other manual therapy applications. It's not difficult. You just need an EMG unit and you're measuring changes before, during, and after. And in general, what you can see with manipulation, this is very related also to the low amplitude, but high velocity, especially the high velocity. We know that after manipulation, there is a decrease in muscle stretch responses. So the reflexes are diminished. Reflexes and tone are equivalent. So this is probably mediated through gamma motor neurons, but we don't know. So there is this decrease affecting reflexes. However, it looks like, in contrast to gamma motor neurons, it looks like SMT, spinal manipulation, could increase alpha motor neuron activity and increase strength. So the muscles are less tonic, but when recruited isometrically, they probably show more strength. These, we don't know if it's purely segmental, Many of the explanations talk about a segmental mechanism, so reflex type of mechanism. But again, some studies point to cortical drive, changes in corticospinal recruitment of alpha motor neurons. And this is again where we can enter the supraspinal mechanisms that you can investigate and that still need to be very much investigated. So I would like to finish here. There's a few more slides where we talk about descending inhibition, and then from here we go up to the brain. I'd like to point to this study because it was published very recently. Before I conclude, this is a very, very well-designed study by, well, the first author is a chiropractor, but then there's a lot of interdisciplinary work here, physical therapist. Tor Wager is the second author. He's a psychologist, very important person in the pain neuroscience. And they looked at what happens in what has been called the neurologic pain signature, which are the parts of the brain that are activated during pain after spinal manipulation to a thoracic spine. And they see changes that can start explain what happens in the brain when we apply manual therapies. There are other studies in this line. Well, some of them are cited down here. I'm not going to go through them, but they are not so well designed. There's a lot of variability in neuroscience design, especially if we introduce the variable of spinal manipulation or any forms of manual therapy. Just think that you can't, if you're doing an MRI, you cannot do a manual therapy inside the MRI. Also, if you're doing PET scan, which is possible, then it's quite complex. So when you're doing the fMRI, for example, you have to measure changes before and after, but there's many other variables that can be affected. So anyway, this is where I finish my presentation. I think I covered what I wanted to cover, and I open you guys in this short time about. I open your eyes to much research that is done and has to be done, and I'm happy to answer questions at the end. Correct, Yuvraj?
I think Bhavana ma'am had one question. Can we take that question, Carlos?
Yeah, of course. Yeah. That's whenever you want. Yeah.
Can you hear me?
I can hear you. Yes.
Yeah. Hi, Carlos. This is Bhavana.
Hello.
I think I should, excellent presentation and new insights, especially with reference to increase in bone density. What is your, have you done, or what is your experience with respect to that?
Well, it's a very good question because this is a study that my co-supervisor for my thesis right now developed. I just participated in the idea, but I had observed in one patient, this was very shocking to me. I had one patient who had undergone 3 times lumbar fusion surgery. The third time they went inside, the bone was so fragile that when they started inserting the screws, it just turned apart. And they closed her and they told her, we can't do anything else for you. So this made me think, okay, these fixation devices, well, they don't allow any movement, and movement is necessary, particularly through the transmission of forces that come from muscle contraction to the bone for our osteocytes to stay active. So if you stabilize, we know that if you have to stabilize your shoulder because of some injury for enough time, you will find decreases in muscle tissue, but also in bone tissue. So I started to think, okay, can you reverse this through movement? And we know that, for example, exercise is very important in osteoporosis. But I started to think, how about local osteoporosis, such as the one that we can see in DJD, in osteoarthritis? Or, for example, how about applying passive forces to people who can't exercise or are in wheelchairs? And this was the general idea. I think that manipulation, mobilization, any manual therapy follow many of the same mechanisms as exercise. And it's just a passive form. It's not the ideal in that sense, but it's a tool that we can use to strengthen the somatic tissues that need movement. That's my take.
Okay, thank you. I think that gives a very new insight. Thank you,
Great.
Carlos.
Great.
That was
Thank
one
you.
question from my side. One, what we understand the neurophysiological effects of manual therapy are far more stressed more on them. Would it be the same story when we talk when we look at soft tissue manual therapy? We spoke.
Well, unfortunately, I'm not. I don't have the expertise for that. I should have dived a little more or dove a bit more into soft tissue manual therapy. I mean, I've read many papers where they mention that many of the same mechanisms are shared by soft tissue manual therapy, particularly the stimulation of muscle receptors. So that's the base, common base for both of them. The thing is that muscle spindle receptors are very speed sensitive. So they're not going to be activated in the same way. So probably the circuits are the same, but the patterns of activation change, which probably have an impact on the clinical consequences. But we don't know. I mean, I don't know. Maybe it's been compared. I know there's a lot of comparison between mobilization and manipulation, and in that sense, there's very little difference. But regarding soft tissue, I don't have enough information, Yuvraj. I'm sorry.
No problem, Carlos. Thank you so much, Carlos. I think we'll get back to you at the end of the discussion.
Great.
Right?
Great.
Hello, sir.
Oh,
Good evening.
yes.
Yeah.
I have
Hello?
one very silly doubt. Can I ask?
Yeah, carry on.
Sir, as you say in this webinar, that threshold go up and sensitivity go down, right? And
Exactly. Yes. I always have to think
Yeah.
twice. Yes.
What does it mean exactly? I have very silly doubt, so I am just now clearing my doubt. So
Okay.
please could you?
Okay. I mean, we don't know how this happened. What is the exact because thresholds depend on Priya. Okay. So we don't know exactly how this happens because thresholds depend on so many things. I mean, for example, for women, the amount of well, for both men and women, the amount of sex hormones change your thresholds dramatically. However, what we do know is that these changes are segmental. What does that mean? That the sensitivity of the tissues innervated by a particular spinal segment or spinal nerve change when the spinal manipulation or mobilization is applied in the area of that spinal nerve or spinal segment. So if you want to affect the threshold here, which is the C6 dermatome, you will have to do your thing at the C6 and particularly C5, C6. What does threshold mean? It's threshold for detection. So imagine before manipulation, I am pressing here. Oh, it hurts. After manipulation, I can press further before it starts hurting. So the threshold is gone up and my pain sensitivity has gone down. I am less sensitive to pain.
Yeah,
which is
okay.
very important in chronic pain states again.
Okay, got.
Thank you so much. Okay, so we will ask the remaining questions to Carlos a little later. So I'll quickly now we'll go back to the presentation. Okay. Okay. So Carlos had a wonderful presentation on research behind it, and I will try to keep it very simple and try to keep it very clinical and try to challenge the existing things around manual therapy which we see here in clinical practice, especially in Mumbai and in India. And one of the things which we always the intention of this speech is not to say this is wrong or this is right, but the question is, can we try to get less wrong as we go ahead, as more and more evidence emerges that way. So one of the basic principles which we teach students is the convex concave rule, which basically which was proposed by McConnell in the 1980s and 1990s, and it basically says when a convex surface moves on concave surface, the direction of the roll and glide would be in the opposite direction, and vice versa. This holds true. This holds true for certain joints, such as the knee and the ankle. However, there are few joints in which this rule, the evidence doesn't support that this rule is getting followed. This is because there are other factors which are are there, such as the effect of muscle force, which is there, the effect of articular geometry, and also the effect of pathology. In fact, in shoulder, it is said if it's a pathological shoulder, you do not necessarily find the convex concave rule being followed, and it will be more of a translatory movement, which is seen especially in pathology, especially in stiff shoulders, rather than glide and slide, which happens. So basically, this is just again reiteration of what Carlos said, is that we cannot for sure say is there a specific glide can improve a specific range of motion. For example, if I want to improve the shoulder flexion, it is difficult to say that I need to give only shoulder posterior glide. There could be other glides which could be as effective, if not more, than the posterior glide. Then there are three rules which Cyriax had done most of his research in the 1960s and 1970s, which were there. One was the capsular pattern, which is basically commenting on is capsule the source of symptom in your thing. And again, the evidence here was very scarce. That is, we found that the hip and shoulder, for example, do not really follow the capsular pattern. In fact, if you take patients with primary frozen shoulder or adduced capsulitis, where capsule is the primary structure, the research found that it is more of the external rotation is definitely the most restricted movement. However, the restriction of abduction and internal rotation may not follow the same order. Like the capsular pattern for shoulder is said to be external rotation more restricted than abduction, more restricted than internal rotation. However, this might not always hold true. That is the thing. So there is a lot of conflict which exists about what is the stable, or the conflict around what is a stable capsular pattern around the joint. End fields. So end fields clearly they suffer from a lot of issues with poor internet reliability. That is, I might feel if I'm assessing a patient, it is more of a soft tissue or a firm end field, and someone else might feel it is more of the bony end field. So there is issues with internet reliability, which comes when you look at the end fields. Cyriax's third concept was the resisted isometric testing, which basically means if you want to further differentiate which kind of active structure is involved, you have to differentiate further between the muscle, the tendon, and the nerve. We do resisted isometric testing, and then there were 4 answers to this, which is strong and painless, strong and painful, weak and painful, and weak and painless. And based on that, we can know the level of injury to the active contractile structures. Again, this holds true in most of the conditions, but there are few conditions, such as if there is a minor contractile tissue lesion, such as there is a lesion of the or in other words we call it tendinopathy, or there's a minor contractile tissue lesion. Initially, the RIT, the resisted testing, would be strong and painful. However, over a period of time, the same person might test strong and painless. So the thing was, there is that this theory may not be applicable to all conditions. When we look at something like in manual therapy, another thing which was there, especially with mobilization, mechanical diagnosis and treatment by McKenzie, it is about disc displacement with repetitive movements. So let me first say that there is a lot of evidence which says that there is this works, and this works very well, especially in patients who show centralization of symptoms on doing repeated movements. So there is a lot of evidence to show that it works. However, the mechanism why it works is something which is not well understood. The theory says it is because of a relocation of the disc. That is, when you bend forward, or if there is pain when you are bending forward, it is mainly because of the disc which is bulging posteriorly and hitting the structures. And when you do repeated extension, the disc moves anteriorly, kind of gets relocated into its original place. This is something which is unsubstantiated. In fact, biomechanical research shows that the nucleus doesn't necessarily move posteriorly with flexion. There have been some studies which show the nucleus actually may move anteriorly, posteriorly with flexion. So that is the thing which is there. So why do we get improvement? As we said, repeated movements do give you improvements, and the reason for improvements may be beyond the theory of disc displacement. There is evidence which shows that the improvements could be possible associated with change in the tension upon the nerve root during repeated loading. So there could be effects of neodynamics which could be there. There could be effect on the other structures which could be there, which could be responsible why you are getting improvement in patient symptoms after repeated movements. Yeah. Okay, and then we have something called as the special test. Now, this is we all are aware of them, and we use special tests to confirm a diagnosis. So, if I'm thinking a patient specifically has a supraspinatal tendinopathy, I want to confirm him by doing the MT-CAN test, and this is the final thing which I do. So, yes, this is pretty helpful. It's not saying it's not helpful, but every time we do a special test, we need to understand limitation of a special test. For example, each test comes with a sensitivity, specificity, a positive and negative likelihood ratio. The MT-CAN test has a sensitivity of 0.62, which basically means of every 100 patients who have supraspinal tendinopathy, only about 62% would test positive using the MT-CAN test. So we need to know, as a clinician, we need to know the limitations of the test which we use. Okay, so this is a famous photo of Chad Cook, and he had written a beautiful book called as Orthopedic Manual Therapy. And what he says is that many of the traditional items associated with manual therapy are no longer supported, be it the convex concave rule, the end feed, the capsular patterns, the positional fault subluxations are not really supported by evidence. And as we just heard Carlos's talks, maybe the effects which we see, are not just limited to the mechanical effects of it, maybe up and above the mechanical effects which we think are actually happening that way. So yeah, so it's the intention is not to leave you at confusion. The intention is also to create some kind of clarity around. So what do we do about it, and what is required, especially for the young clinicians who are there or listening to this, is that it's very important to recognize methods outside your own clinical practice. That is, if I follow a certain school of thought, I follow McKenzie's MDT. Yes, that is wonderful, but there could be reasons why improvements happening which are up and beyond just MDT, and we need to be reading a lot, and we need to be aware of other mechanisms which are in action. Techniques which are based on customs, habits, promotions, or protocols should be questioned. That is one thing, and it's also important. Many times we see there are very complex theoretical or biomechanical models which are used to explain a clinical phenomena. However, they have very little carryover to clinical care, not evidence based. So we need to be careful about those also. So what should we do as clinicians? And that is, A, would be read a lot of research, recent research, and use techniques which are extracted from clinical trials. And that is the most same thing to do, I feel. Use outcome measures, ensure you are assessing your patients pre-treatment, post-treatment is very, very, very crucial. And the last thing is something which will, again, I'll come back to this, is that integrate patient responses along in your examination and treatment processes. And I will get back to this a little later. So that is about the thing. Okay, so that was about manual therapy. Carlos nicely explained of what are the possible things which could be working instead of just mechanical effects. And what I want to stress is that many of the conventional things which we believe in manual therapy are now being challenged, are now being questioned. Okay, so that is about manual therapy. I will hand it the discussion now to Pradnya, who will quickly tell us about a few of the myths around exercise therapy. Pradnya, over to you.
Hello.
Yes, you're audible, Pradnya.
Am I audible?
Yes.
Yeah. So that was quite a presentation by Carlos and Yuvraj, and we really thanks Carlos, because he is in the midst of his PhD thesis submission and he still accepted our invitation to go ahead with the presentation, and a very insightful talk. He shared with us his experiences. Now we are going to move on to exercise therapy. Now basically, physiotherapy, as we all are being taught, that it's a movement science, and exercise forms an integral part of our clinical practice, of our rehab, and that's what we have always been taught. I still remember back into my second year when we were taught stretching, and we were so enthusiastic about it that if we had to give stretching to somebody, we would always jump onto it, that yes, I want to do. But there are certain things, as manual therapy has evolved over a period of years, there are certain concepts which we now think twice before using them. So there are few concepts in exercise therapy which have now slowly started losing their charm. And the first thing that we will be talking about is stretching. So we generally stretch because it feels good, because we believe that it improves our mobility, and we believe that it is a must thing to do before we start off any exercise or before we move on to any workout session. But there's a lot of research and evidence going around stretching, which is now being questioned. So first and foremost, when we talk about static versus dynamic flexibility, now let us remember that the kind of stretching that we generally do is basically majority of us do a static stretch. Now static stretch, though good, but has been now shown that when it is done alone has been having no beneficial effects as compared to your dynamic stretching. So when we talk about doing a stretch statically, what it has been shown, evidence shows that it hampers performance because it leads to relaxation of the muscles and it calms down your central nervous system. Whereas when you're doing a dynamic stretching, it prepares your muscles as well as the passive supporting structures of your body for the upcoming activity. So whenever you are going to do a workout, if you're going to be in a sport and just before your match, you do a static stretch, you are going to relax that muscle. So thus it is going to hamper your performance. Whereas if you dynamically do a part of that sport as a workout. So supposedly you are a sprint runner, you do spot jogs, you do certain lunge rotations, you do certain amount of exercise wherein you're dynamically keeping your body moving. That is going to actually keep your nervous system activated. It will improve your inter and intramuscular coordination, increase the blood flow to the muscles, and thus prepare your body for the activity that has to come. When viewed in isolation, the static stretches can be misleading. So when we look at the whole body as a normal movement, so supposedly you are preparing yourself to be running and you found that your ankle is stiff. So you stretch your plantar flexors, you try and get that range in your plantar flexors. And do you think you will be able to run? No, because a movement or for you to have a normal performance, what you need is also balance, coordination, postural control, and perception contribute perception towards a normal movement. So when all of these factors are responsible for producing a movement, you cannot isolate a particularly tight muscle and contribute it to be a leading factor for your for your poor performance. Now, what are the factors which affect your flexibility? There are general basic three factors, which is your activity level. If you have been an active person, you will tend to be more flexible than an inactive person. So currently in this lockdown period, I'm sure when all of us have been working from home and have been made to sit at a particular place, you would realize that your body is becoming a bit stiffer. So that is not actually the stiffness, but it is the inactivity that is producing that feeling of stiffness. Your stretch tolerance. Majority of us feel good when we stretch. So is that the muscle that is lengthening? We need to question this a lot. It is actually not the muscle that is lengthening, but it's your tolerance towards the stretch that improves. And age and sex, usually we see that as we get older, your body tries to get stiffer. But if you have been an active individual, age definitely has no correlation with your flexibility component. If you have been active, been exercising throughout your life, you would still be flexible even if you're 90. Then there are most of the articles which are now retiring flexibility as a major component of your physical fitness. If you go through your ACSM guidelines, you would still find that flexibility forms one of the major components of your physical fitness. We still do in long sitting toe touching exercise test as a component of your flexibility. We try to judge whether a person is flexible. So no matter what sport he is playing, but is that component going to count for the performance? No. So stretching, role of stretching in preventing injuries is questionable. There's a good article which we will be sharing with all of you, because stretching lacks predictive value with meaningful health and performance outcomes. You need to have flexibility. So if stretching is not the answer to get that flexibility, what are the other options? So there are a lot of other robust exercises. Most of your body weight exercises, your dynamic forms of movement, which can still maintain the flexibility and keep your muscle active for the performance without going into static or passive stretching. Okay, next slide. So let us have a look at few of the exercises that we usually do for stretching. So this is one example. Of active hamstring stretch that we generally follow. So you make the person sit at a height with the spine maintained in a neutral position. You can be a bit lordotic and then ask the person to straighten both the knees as much as possible without moving from the spine. Can we go back to the videos?
Just a second. I think the video has got it.
Yeah.
But then you can continue talking in the meanwhile. I'll just get back to this. Pradnya, can you hear me? Pradnya, can you hear me? Pradnya, are you there?
Tell me.
Yeah. I would say carry on with the discussion. Just get back to the video. Okay. Pradnya, continue. Okay.
Yeah, I can't see the presentation. Can you share the screen?
Yeah, exactly. Can you see the screen now? Yeah, continue, Pradnya.
So there are a lot of other ways in which we can still maintain the flexibility in our muscles and the surrounding structures without going for static stretching. So we have given you a few examples of this is latissimus dorsi stretch, which the person is doing. There is as much elevation of the arm as you can do with the hand staying as close to the ear as possible. This is an active stretch that a person does. and you hold the position for almost 20-25 seconds, and you can do it in a set of 3. Then when we are talking about flexibility, we cannot forget that it's not just the muscles which become tight, but there are other structures like your fascia, your ligaments, and other non-contractile structures which need to be worked upon. So windmill stretch is a very good example of allowing all of those structures to be stretched in a very nice way. So this is an example of an exercise which integrates your muscle as well as your fascia for stretching and improving the mobility. Then we have something called as a lunge rotation, which you can incorporate into most of your sports activities. So if it's a person who is an athlete and who needs to have these kind of flexibility, so a combination of movements which will work on the whole kinetic chain. So this particular stretch is going to work on the posterior and the lateral kinetic chain very nicely to get you a good flexibility and movement component. So it's very important that you start with a baseline exercise and move on to the complex components which will involve most of your body parts, and that itself will help you get to mobility. Now, when we are talking about rehabilitating a patient, there's a very nice concept of load capacity model which was published in British Journal of Sports Medicine. Whenever we have an increase in load, so this is the load part, and if there's a subtle increase in load, the tissue has the capacity to adapt, as you can see from the first picture. But if you increase the load suddenly, the body has less capacity to adapt to that sudden increase in load, and which predisposes your body to injury. Now, what happens when you're in pain or when you're injured? Your most of the common advice that we give is a prolonged unloading. You advise them to rest that part. You advise them not to move. But if the loading is prolonged beyond a particular time, what it is going to do? In the initial phase of unloading, the capacity of the body will reduce, but not to a great extent. Whereas if you are continuing deloading the structures, unloading is continued, then the body's capacity or the tissue capacity goes down drastically, and this may predispose you to weakness. So what happens here is something called as disuse atrophy that we usually see. Okay. Now, what most of the research is saying, you have an injury, you deloaded the structure. Now you gradually start increasing the load on the structure. As you can see, if you're increasing the load on the structure slowly, the tissue capacity increases. So body heals and its force starts increasing in a calculated way. So what you have here is a very progressive return of tissue to its pre-injury levels if the load has been managed considerably. Now, when we come to the strength exercises, you have to remember that your rehab always, whether it's a sports person who has come to you or it's a normal person who has come to you, you classify the rehab into a musculoskeletal or into a return to play sports. So initially, as always, you depend upon your passive modalities, your motor control exercises, because the first target is to manage and control the pain. The next aim is to normalize the movement pattern. Over here, you start with low load precision exercises, wherein the stress on the structures is less, but you still start strengthening the muscles. Then you move to the advanced exercises, wherein you start adding body weight, or you can add low impact exercises with TheraBand. When it's a sports person, if you stop here, you will not be able to make him go back to his sports. So you always need to go to these levels of body weight training, like include planks, burpees, animal flow. Move on to the structural exercises, wherein you are making them do a loaded deadlift, squats. So you are gradually increasing the load on the structure, and you will see that the capacity of the body to return back to pre-injury level also improves. You eventually end up with plyometrics and Olympic lifts and sport-specific activities for the patient. So here are a few examples of certain exercises that we do, which we have uploaded on the YouTube, and you can have a look at our Insta page. Now, much has been spoken about posture. We always try and assess the posture of the patient. If somebody complains of pain, we come and say that, have you sat long, or have you stood for long hours, or is there a particular way that you've been moving? But research currently has said that this is the perceived importance of posture, which you see in the red block, but the actual importance of posture is only this much when you actually come to rehabilitating a patient. Okay, so always remember this. We have taken it from Sullivan's article, that there is no single correct posture. There is no evidence that an optimal posture exists. There are differences in postures are a fact of life. You have to remember that posture reflects beliefs and moods. So it is a great idea to assess posture just to know what is the belief of the person behind that pain, because a person in pain is going to adopt a particular posture. So emotions and thoughts are responsible for that. Some postures are adopted as a protective strategy. It is safe to adopt more comforting postures. So right now, those who are working from home, even if you slouch and work, there's no harm. Okay, rather some postures provide symptomatic relief. If you have seen a person who's got an acute disc or an acute pain, you would see him guarded and standing very erect. The moment you ask them to slouch a bit, they would say, yeah, that actually feels good. So remember that there's no harm in adopting a comforting posture, but you have to keep changing those movements, those postures. And remember this one thing, we have made our spine most weaker component. We think that it's weak. We think that bending forward, twisting is going to harm my spine. But you have to remember that your spine is robust and can be trusted. It is very strong. So common warnings to protect the spine are not evidence informed and can lead to fear. Many a times we tell most of our patients, whenever you're moving, whenever you're trying to get out of your posture, tuck your tummy in, brace your spine, because it is not comfortable to, it might injure your spine. So that is not the fact. Sitting is not dangerous. If you sit for more than 30 minutes, also it's fine. But so long you have to keep changing and create a variability in that posture. Moving is good. Being physically active is very important. So sustaining a particular posture beyond a particular time might lead to some discomfort, but that is not a warning sign. Can we move on to the next? And always remember that one size does not fit all. So a particular posture is not an answer to every person. Screening of posture doesn't contribute to pain management. Different lifting strategies are adopted usually by persons. So if a heavy laborer comes to you and he says, I'm comfortable lifting the weights by bending from my back, and I've been doing this for ages together, just because he's got a pain episode today, you cannot tell him that you have to bend from your knees. Okay. So when we are talking of all of these, it is very important. I would like to just emphasize this, that you have to assess posture to rule out serious deformities like scoliosis, kyphosis, kypholordosis, something that is going towards a structural part. Okay, you have to screen posture to understand the basic psychology of the person towards the management of the pain. These are two important things wherein you would use posture as a screening tool, but don't rely on posture to chalk out an exercise regime for your patients, or don't blame a particular posture for a particular symptom in a patient, because that's the way the person has been used to be.
Okay. Thank you, Pradnya. I will just take over from here. And we agree we might have created a lot of confusion about this is a myth and this doesn't work, and but now we try to, in the last 5 minutes, let me just try to bring together everything and try to make sense of it. And this concept of narrative diagnosis I was introduced when we worked with the likes of Margareta Nordin and Carlos, who had come down to us, and I felt it was such a simple way of going about musculoskeletal therapy, which helps a physiotherapist to create treatments which are precise to the patient. The diagnosis which we are creating changed from being pathology-based assessment, which we discussed, to impairment-based assessment, to a combined pathology and impairment-based model, where we had the categories of hypothesis, and now we are moving towards a patient-based, patient response-based model. And for those students, for those clinicians who want to read more about this, the book to read is Chad Cook, orthopedic manual therapy, and he has given quite nicely about what is meant by patient-based model. Basically, it combines the good things of your biomedical model, the biomechanical model, and then puts one more layer to it, which is of the patient responses to it, that way. As I always say, there's nothing called as right or wrong. As we are learning, we are trying to get less and less wrong as we move ahead in our careers. So basically, this system, patient-based system, basically means about three things: examination, treatment, and re-examination. So if I see an impairment, such as a anteriorly tilted, yeah, or if a person is having shoulder pain when he's doing shoulder elevation, and I observe that he has a reduced upward pressure of scapula, and which could be responsible for this. So yes, that is an impairment. But is that a relevant impairment to me? For that, I will try to do a load modification of trying to passively correct the scapula and make it move towards upward rotation when he is moving. And if that significantly changes his symptoms, there is a less pain and there is a significantly improved range of motion when I do that, this is a relevant impairment for me. And that is the thing about examination, treatment, and re-examination that way. And if there is no change, I don't know. I might want to, I might select to move ahead and to try something else to do this. So that is basically the essence of patient-based approach, is that you are going to, you need to know the pathology, you need to know the biomechanics, you need to know the biomechanical principles behind it. But at the same time, you are not going to treat everything which you see with the same level of importance. You are going to actually try out corrections, active corrections, passive corrections, and try to see which are those impairments which directly apply to our patient's symptoms. That way. So another thing, so after the entire assessment is done, basically we have to just answer three questions. Is that what is the nature of the symptom? Are these acute, chronic, or acute and chronic? What is the mechanism of onset? Is it mechanical? Is it micro trauma? Is it micro trauma? Is it degenerative? What? And the third thing is the structure which I'm thinking is involved. Is it a mechanical structure? Is it discogenic? Is it a joint dysfunction? Or is it tissue? Or is it a neurogenic thing? So at the same time, based on our examination, treatment, re-examination, we are going to identify the relevant impairments which are there, such as the anterior tip scapula, or it could be a myofascial trigger point over the levator scapulae. So when we come to a diagnosis, we need to answer four questions. One is the nature, one is the mechanism of onset, one are the what structures we believe are causing this problem, and then we are going to note what are the impairments which we feel are the most relevant impairments to our patients. So your diagnosis could something look like a acute mechanical discogenic low back pain with trigger points over outer Gmax. Now, when a physiotherapist makes such a diagnosis, it is easy to treat now. It is easy to treat, and we'll look into that later. And this kind of a narrative diagnosis, and this can go on. There is no rule it has to. So it could be acute mechanical discogenic low back pain with trigger points over Gmax or IT, whichever thing you feel was relevant to your patient, was making your patient feel better. So that is the thing about your patient-based model. The diagnosis could be left-sided chronic microtraumatic supraspinatus tendinopathy with a downward rotated scapula and a myofascial trigger points or rhomboids. So it could be this way. Okay. And in musculoskeletal, the next thing which is there, and we'll come back to how to treat this a little on the next slide to this. In musculoskeletal physiotherapy, another thing which has come up big way through big data and artificial intelligence is the effect of negative pain influencers on the musculoskeletal problems. Such as, for example, sleep deficit is now coming up as one of the very important predictors of chronic pain. So in your patient, apart from coming to narrative diagnosis, it's very important for us to identify what are the negative pain influencers. They could be lifestyle pain, such as sleep deficit, obesity, smoking, low or highly erratic activity levels, excessive screen time, that is watching a mobile phone for more than 30 minutes before you go off to sleep. Coping strategies, is he having avoidance-based coping strategy or is he having the endurance-based coping strategy? Emotional, stress, fear, anxiety, etc. Social, lower socioeconomic status, poor health literacy, cognitive, such as a tendency to have catastrophizing behaviors, tendency to be hyper vigilant about his symptoms, and physical negative influences such as erratic physical loading or deconditioning. So a person who comes to us with shoulder pain and whom we diagnosed as chronic microtraumatic supraspinal tendinopathy with downward scapula, we also need to understand, we also need to find out, we also need to note his negative pain influence. It could be, we need to ask questions like, how much hours do you get to sleep every day? And maybe it is the sleep deficit which is contributing to the chronicity of the symptoms. Maybe it is obesity which is contributing to chronicity of his symptoms. Maybe it is his coping strategies of endurance, that is, in spite of having pain, he's continuing to work, which we might want to challenge. So it's very important that we are able to identify the negative pain influences which are there in our patients. So once we know, once we are able to come to narrative diagnosis, and once we are able to identify the negative pain influence, management is actually, it just flows. For example, let's take a diagnosis of a 55-year-old male with left-sided chronic microtraumatic supraspinal tendinopathy with downward scapula and myofascial trigger points over the rhomboids. And in terms of negative pain influencers, there was obesity, there was sleep deficit, and there was evidence that he was not doing enough exercise. There was a deconditioning. Now, treatment is simple. The first word is chronic. Okay, what this means is that I have to encourage movements, I have to encourage activities, and I can be more aggressive with my treatments. Microtraumatic supraspinal tendinopathy. I am going to now, we need to know how to treat tendinopathy. What is the evidence? What are the evidence in treating each structure? So I'm going to start the isometric exercise, progress to eccentric exercises, and then move on to involving the entire kinetic chain. I have identified that his downward rotated scapula has been a very relevant impairment in him, and that's why I'm going to work on restoring the balance between the scapula rotators and scapular rotators. I'm going to maybe work on activation of serratus anterior and maybe work on the release of his downward rotator scapula, such as the rhomboids and the levator scapulae. And for myofascial trigger points of rhomboids, I can do self MFR or active stretch. Now this can change. See, understand? It's like if I have this diagnosis in front of me and I am not there in the clinic and I give the patient to someone else, and someone else who is there may be well versed with, instead of being good with myofascial releases, he or she is better with doing taping, or he or she is better with doing dry needling. Fair enough, use that. Fair enough, use that. Is that, but the narrative diagnosis has to remain the same. So that person can choose to release the myofascial trigger point. They might use taping. I might use MET. I might use MFR. Somebody else might choose something else. Somebody used to choose to tape the scapula in a certain position, and that's okay. Point is, this kind of diagnosis will help us physiotherapists come to a treatment which is far more precise for our patients. Now, it's important not to ignore the negative pain influences, and we said we have observed this obesity, sleep deficit, and deconditioning, and then with this, I'm going to the management, which would be more of counseling and reassurance and encouraging more physical activity and relaxation methods. Maybe we can ask him to start going for walks that way. And then finally, it's important to encourage him to take up a sport or join a gym or something like that once the symptoms are subsided. We always, what we do is we definitely ask the patient what is that they want to get back to. So most of patients who come will want to get back to an activity or a or a sport or dance or something like that, like it, and that is a wonderful way to encourage them that slowly we will be able to take you to that. So what happens with this narrative diagnosis is that we are free in using a technique which we feel we are confident working with. However, the diagnosis remains the same. I use this diagnosis and I pass it to the next person, and he or she uses what he or she is good at using them. Okay, so that is about the narrative diagnosis. And as the series goes on, we are going to discuss a lot about how to identify the relevant impairments, how to identify, how to create precise treatments for these relevant impairments, which we just spoke about. That way. Key takeaways from these lectures and would be, as Carlos nicely explained, about the current concepts in manual therapy. Mobilization manipulations are almost the same in terms of effects. The effects of manual therapy are up and beyond the mechanical effects. There are effects which are neurophysiological in nature, and we would share the articles with you very soon. You can look at the link in the description a little later, and we will share the articles with you about manual therapy. And it's very important for us to read them, to understand what is that is actually making a difference to our patients, because this is something which, and when we talk to our colleagues from medicine, from orthopedics, it's important to explain exactly how is our manual therapy making a difference to our patients. It's important for us to read research around manual therapy and use techniques which are extracted from clinical trials, rather than believing in habits, rather than believing in protocols. The load capacity model, again, it's a beautiful 6 minutes video, and I will share the link in the description a little later. Is that it's very important that we start with basic exercises, we start with slow exercises, but we are able to progress it to higher intensity exercises. The more you load a structure, the more the capacity of the structure improves. It's not just the muscles, it is the ligaments, the bones, the capsule, the tendons, everything, the capacity of them starts improving. So yes, that is one of the things which we are going to stress a lot on, progressive loading of structures to improve the capacity of the structures. A patient-based approach to clinical reasoning is that yes, you need to know the pathology, you need to know your mechanics, you need to know your biomechanics, but it's also important to understand what is that works for my patient, what is those three impairments which will make a big difference to my patient, and it's important to get to them. And that is how your treatments will become precise. There is a lot of trial and error in this. There is examination, treatment, re-examination, which we keep on doing to finally come to think that this is one thing which helps my patients, and not to just base our treatment just because we see an impairment. You need to correct it, check it, recheck it. That way. It's important to identify the negative pain influences in your patient, be it lifestyle, be it coping, be it physical, and we need to read more, because we are the final ones who are treating pain a lot, and we need to know what is the effect of sleep deprivation on pain, what is the effect of stress on pain, and we need to know this, because finally that is one thing which we are treating the most that way. Narrative diagnosis is a very interesting way, very easy way, at least clinically, I would say, which I have found very useful. Is that please try to read more about that, and I will give you the links about this in the description. Is that get to a diagnosis of nature, mechanism, onset, and structure, and the relevant impairments. If you are able to get this, you should be able to do wonderful. Yes, I think before we end the discussion, let me just tell you, on Tuesday we are going to have the second part of our discussion, which is about challenges of rehabilitating an athletic shoulder, and we have one of a very elite cricket fast bowling coach with us, Prasad Kanade, who has academy in Pune, and he trained at the MRF Pace Foundation, and he was captain of Maharashtra Ranji Trophy team, and he's going to tell us about more about what are the throwing drills which are there. We have a lot of musculoskeletal topics which we are going to discuss during this series of 12 lectures. There is a topic on nerve pain, there is a topic on spine pain, looking beyond strength and flexibility. We are very lucky to have our friend from strength and conditioning to help us with understanding how to integrate strength training in rehabilitation, what is the role of maximal explosive strength in rehabilitation. So that is one of the 3 lectures which are going to happen. And then we are going to have some lectures on sports rehab, about what is the role of a person when he's going for training a marathon runner. Really possible. We have some very exciting people who are there. So yes, if you find this is exciting, please feel free to contact us. But before we end, I hope this was good. I hope this was useful. We try to keep it as short as possible. I think we have overshoot by some minutes, but yeah, if there are any questions, we would like to take them now. Carlos is there, Pradna is there, I'm there. So yeah, if you have any questions, I think there's one question on YouTube. Ocean. Carlos, this is one question which one of the persons had asked, and this question is: does spinal manipulation have any effect on central sensitization of pain? So, does spinal manipulation have any effect on central pathways?
Well, as I presented before, there is quite a lot of data suggesting that there is an influence on central processes. Specifically, central sensitization is it's actually a pretty controversial concept, and we can't measure directly. We can measure its effects. And there's a couple of papers that show, for example, that spinal manipulation can decrease secondary hyperalgesia, which is increased sensitivity, but outside of the area of injury. But there's not enough evidence in that direction yet. So we don't know. However, one of the key elements that predispose to central sensitization of pain is increased temporal summation. So when pain is continually entering. So there is some data, like I presented before, that manipulation and mobilization could have a positive influence in that sense, but it's still early. Still early.
Yeah. And Carlos, what are your views on your negative pain influences such as sleep deficit? Do you have any reading on that, and how important it is for physiotherapist or a chiropractor to look more into or probe more into the negative pain influences?
Well, actually, Balowski, who I talked about before, he's done a lot of research in that sense. In general, he's compared positive expectations to specific effects of manipulation, and he found that manipulation does have effects beyond positive expectations. However, when you have negative expectations, it's very hard to override them. There's also some research that shows that even with, with high levels of pain catastrophizing, the outcomes are immediately worse. So it's very hard to overcome those if you don't really go and have a psychotherapy-based approach or a cognitive behavioral therapy or CBT or CFT, that kind of thing. Yeah, I think you need to complement in those patients with very negative expectations or beliefs like catastrophizing, high levels of catastrophizing. Yeah.
And what about something like deconditioning or lack of physical activity, Carlos? Does that affect the outcomes of a patient? Are you aware of anything like that?
I don't know the data in that sense. I don't know. I mean, I imagine that just like anything else, deconditioning will affect many systems, not just the musculoskeletal system, but also the cardiovascular system. So these patients are definitely going to respond less. So I think in those cases, reaching a proper level of fitness before intervention is probably preferable, to get them first in shape, in an acceptable shape. People who've been on a wheelchair or who had for example, paralyzed leg for a long-term injury. It's better, I think, to before doing any type of manual approach, to first work on active approaches, so exercise before. But I don't know the data there.
Okay. Thank you so much, Carlos. Vikas sir, do you have any inputs? How did you find the presentation? How you liked it?
Definitely excellent presentations by all three of you. And when Carlos was talking, it took me back almost for 42 years when our Professor Shani introduced us to the concept of neurophysiology. And I could recollect so many terms there, and I found it really thought-provoking. and how much more has come into neurophysiology, which is enlightening us to make physiotherapy more effective. And nowadays, what is happening is there are many patients who come with a lot of knowledge. They have kind of pre-researched what they are suffering from. And it gives this insight to make them understand that what is wrong with them and how physiotherapy is going to help them. So they really appreciate that, and that gives us better results because they know what is there and what they also need to do. So it's a win-win situation for everybody. So thank you very much, all of you. And it was an excellent time spent with you guys. Thank you very much.
Thank you so much, sir. Bhavana ma'am, any last closing comments from you? Would really like to know how you like this.
Can you hear me?
Yes, ma'am.
Yes, congratulations, Yuvraj, for initiating this thought-provoking sessions. And I fully agree with Vikas that everything was introduced to us thanks to Professor Shahani. And it was very interesting what Carlos talked and the new ideas that you shared with respect to manual therapy and stretching exercises and the exercise concept. The model of exercise from low intensity to high intensity, I think, was presented very well. Only thing I would like to say that alignment does play an important part. And I disagree on that, what Neha says. Neha, otherwise it was very good presentation.
That's okay.
It has
I think that there has to be a lot of opinion together, ma'am, for us to come to it's important for that to, intelligent discussion.
Because if you don't have your alignment, you don't have your muscle length, appropriate muscle length, and muscle length tension, what we studied in Starling's law still holds good.
Yeah.
So there are certain concepts. Of course, what she said was right, that when you are in pain, you don't try to correct the posture. That I fully agree with her. But we need to have an alignment. That is a necessity. And what I think you have summarized everything very nicely is the framework of ICF, where the contextual factors are also given importance. So I think all the participants will definitely benefit through your further sessions.
Thank you so much, ma'am. Thank you so much, sir.
Thank
and
you.
I hope you do join us for the remaining sessions. The next session is on athletic shoulder, and yeah, thank you so much, Carlos, for finding time from a busy schedule and helping us with this. And it was really wonderful to hear your views on what's great in manual therapy. Thank you so much, guys.
Thank you for inviting me. Have a great night.
Thank you so much. Bye, guys. Take
Thank
care.
you, sir.
Bye.
Stay safe. Bye.
Thank you. Bye. Bye.
Thank you.